Good afternoon. Thank you for joining us at EHJ today. I'm Robert Ye from the Massachusetts General Hospital, and I'm joined by Martine Gillard from the University of Brest, as well as Christophe Leclerc from the University of Rennes. We're going to be speaking about the Italic study today. We'll start with you, Martine. You were the principal investigator of the Italic trial. Tell us why you conducted this trial and what was the rationale for it.
So this trial begins since 2008. So at this time, the very important question was, we can stop dual antiplatelet therapy at 6 months, or do we have to go more than 1 year? Because there is, as you remember, the September Black of 2006, where we said after DES there is a lot of stent thrombosis. So the question was 6 months or more than 1, so 2 years of dual antiplatelet therapy. Is why we conduct this trial, in order to have the answer about this very important question.
Tell us what you found in the trial.
So it was a non-inferiority trial about comparing 6 months versus 2 years of dual antiplatelet therapy, and we decided to implant only one type of stent, the new generation of DES. It was a Science V stent from Abbott Vascular. Why? Because we want to have not too much patient to include in order to reduce the component of the stent, in order to have not a lot of difference according the safety, according the efficacy, if we use a lot of stents. So we decide to use only one new generation of stents, and we test the patient in order to see if the patient have a good responder to aspirin. Because at 6 months we decide to stop the tienoperidine and to leave the patient only with aspirin. And at this time, on 2008, it was very new, so we prefer to have our patient treated with aspirin. So we check the resistance or the good response to our patient with aspirin. If patients are not a good responder to aspirin, these patients are not included in our trial. And for the other, we randomize at 6 months, and at 6 months, the one group was no aspirin at all, just aspirin, not tienoperidine at all, and the other group go on until 18 months in order to have double antiplatelet therapy. If during the 6 first months some events occur, like thrombotic events, bleeding events, the randomize was not applied to this patient. So we just leave patient during 6 months without any events, and then we apply the randomization 6 months versus 2 years.
Okay, and what were the results of the trial?
And we are very surprising, because we expect a rate of event of 3%, and it was only 1.5% for the group of 6 months, and 1.6% of events in the group of 2 years. And it was very low as events. And when you compare to the result of ISAR SAFE, the other trial presenting during the late-breaking trial, it was from Germany. The rate of events is exactly the same, 1.5%. So there is no difference at all between the two groups of dual antiplatelet therapy. There is there is not an increasing of bleeding in the group of dual antiplatelet therapy since 2 years. Exactly the same rate of bleeding, exactly the same rate of death, exactly the same rate of events in the two groups. So we reach the non-inferiority, and our trial was positive. We can stop dual antiplatelet therapy after 6 months, after a new generation DES implantation.
Christophe, let me ask you, you probably saw the results of the other other similar trials evaluating dual antiplatelet therapy duration, and as well as previous trials that have been published. How do you interpret these findings from Italic with the other studies that have been published and presented?
I think that the result of the Italic trial are very important, because this strengthens the new guidelines of the ESC, because now antiplatelet therapy is dual antiplatelet therapy is recommended for 6 months treatment. But I must say that I very like the design of the Italic trial, because it was the only trial we tested the resistance to aspirin. And so to avoid to include the patient in whom it would be deleterious to keep on with only aspirin. So I think it was a very good thing to do that. And I think that we have to stress this particularity of the Italic trial, because, and just say, not to say to people, okay, you can stop after 6 months. You can stop after 6 months, but before you have to check that your patient is not resistant to aspirin. So I think it's a very important thing. The other comment I can make is that with the new generation of stent, and it's a very good news, we see that we decrease the rate of complication and especially stent thrombosis. So I think that this is also probably an explanation of the fact that when you reduce the duration of dual antiplatelet therapy, you don't have more event. And of course, you can expect to have less bleed. But also another point I want to check in your study, Martin, is that you excluded also patients who were very at high risk of coronary event, especially stent thrombosis. And I think that this has to be very clear. The message we have to give to the audience is that the patient we have an event during the first 6 months were excluded. So it was patient with stable coronary disease for 6 months without resistant to aspirin. So I think it's a very important message.
I think that this is one of the reasons why your event rate was so low, excluding the higher risk patients with ST elevation MI, for example, excluding the higher risk patients who might have had aspirin resistance. Is this why your event rate was lower than you anticipated?
Yes, but when you compare to these are-safe who have not the same design, but if they compare 6 months versus 12 months with every type of stent, but new generation, and no testing the resistance of aspirin, they are exactly the same rate of events, 1.3 or 1.4% of events. So it's, I think that with the new generation of DES, I think the rate of events are very low. So it's very important things.
Martin, tell us what percentage of the patients that you tested for aspirin resistance were found to actually be aspirin resistant? And two, should we be routinely then testing aspirin resistance in clinical practice?
It's a very, very important question. We have only 137 patients who are not good responders to aspirin, around 2,080% of patients, or 80 patients. So it's not a lot of patients, and we follow equally this group. There are not a lot of events also. So, but this group are not, they go on the dual antiplatelet therapy, but the rate of events in this group with a resistance of aspirin was exactly the same than the other.
Yes, Martin, but I think that, as you mentioned, for this patient we had a resistance to aspirin, you didn't stop the dual antiplatelet therapy. So, personally, from a clinical perspective, I'm not yet interventional cardiologist, but I think that the message for the general cardiologist should be that you can stop for me, you can stop at 6 months, but I think it's wise to look at the resistance to aspirin, because so you will be more confident to stop if you need the dual antiplatelet therapy after 6 months of treatment.
I was interested in the finding of no difference in bleeding between the two groups. I think we have a large body of evidence suggesting that prolonged dual antiplatelet therapy does increase bleeding. Tell us a little bit about why we found that in your study.
You have to remember that our trial used in 98% of cases clopidogrel. It's not the new antiplatelet therapy with the increasing of bleeding. So, and also, as Christophe mentioned, we not include patients who have an event of bleeding during the first 6 months. So I think that the patients who are selected and enrolled in our trial are very stable patients with comparing to aspirin and something of bleeding. So it's perhaps why we have not a lot of bleeding effect. It's exactly the same with are-safe also. So these two new trials about comparison of dual antiplatelet therapy prolongation or shorter arm, they have not an increase of bleeding in the two arms. So it's a very new finding also, comparing to the previous trial.
Yeah, I just want to make a comment also, because we're discussing about 6 months versus 2 years. But the result presented yesterday was a 1-year follow-up. So it was a primary input was that 1-year follow-up, and so we are expecting the result at the end of the 2 years, and perhaps after two years we will see a significant increase of bleeding, because we have to keep in mind that the patient has just 6 months more of dual antiplatelet therapy. So I think that, especially for safety, I think it will be very interesting to have the result after 2 years.
Christophe, tell us how these study results will change your practice.
I must say that we have different, yesterday during the late-breaking trial, we had different approaches. The European approach was to show that we can reduce the duration of the dual antiplatelet therapy, and the other trial, the US trial, the DAPT trial, was designed to increase the duration. So there are two different philosophies, but I think that in patients we have a low risk of cardiovascular event, especially patients with a high risk of bleeding. I think that now we have data to decrease the duration of dual antiplatelet therapy, but in contrast, in patients with very high risk of cardiovascular event, especially a coronary event, probably we need to increase the duration of. So it's difficult according to the characteristic of the patient, as mentioned by Gilles Montalesco yesterday. The conclusion that we have to make a tailored prescription for antiplatelet therapy. There is no one rule for everybody, but I think that we have to take into consideration the baseline characteristic for the risk of bleeding and also for the risk of coronary events. So it's a nice side of our job, because we are not only computer, we have to think about for each individual patient.
And Martine, I'll ask you to give us the final takeaway from your study.
So the takeaway, I think we are sure now that we can stop dual antiplatelet therapy at 6 months after new generation of DES, but not with the first one or with. However, we have to tailor, as exactly as Christophe said, we have to tailor to the patient. If a patient have a high risk of thrombotic events, like for example a PCI of left main or a multivessel disease with a lot of stent inside the coronary artery disease, I think this patient could benefit of more than 6 months dual antiplatelet therapy. So for the vast majority, 6 months, but for patients at high risk of thrombotic events, more than 6 months.
Well, I think it's been a terrific discussion about your study, and congratulations on a wonderful study that you've conducted and presented today. Martine, Christophe, thank you so much for joining us, and thank you for joining us on EHJ today.